Now for the second bout, bout number 18, I would like to invite Dr. G.R. Badlani, Dr. Manish Agrawal, Dr. Devendra Singh Jhala, Dr. Dharmesh Solanki, Dr. Pawan Roy, and Dr. Nilesh Purushottam. The topic is diabetes and heart failure, SGLT2 inhibitors. I would like to request Dr. Badlani to kindly introduce our speaker. Dr. G.R. Badlani, please.
Good morning, everyone. At the outset, I want to thank Dr. Kambal Sharma and the whole Cardiocon team for giving me this opportunity to moderate the session. And as we all know, this is bout number 18, and the topic is diabetes and heart failure. Yesterday, we discussed the heart failure, and today is diabetes with heart failure with particular emphasis on SGLT2 inhibitors. For that, we have three speakers. And the first speaker is Dr. Soumitra Ray. He's the Director of Invasive Cardiology, AMRA Hospital, Calcutta. He's the ex-professor, Vivekananda Institute of Medical Sciences. He's the ex-vice president of CSI. He stood first in order of merit in higher secondary, MBBS and MD, all the exams. And he later on pursued MRCP in UK after MD from Calcutta Medical College. He's trained in interventional cardiology at Royal London Hospital, London. And he has published many papers, reviewed many articles, and written many chapters in cardiology books in India and abroad. And he is in the editorial board of Indian Heart Journal and Journal of Diabetic Dyslipidemia. And he represented CSI in interventional conferences. And he's the founder president of Calcutta Cardiology Association. Welcome, Dr. Soumitra Ray. Then we have another speaker. He is a well-known figure in Ahmedabad, Dr. Sanjeev Phatak. He's a renowned cardiologist and physician in Ahmedabad. He's at Vijay Ratna Diabetic Diagnostic and Treatment Center. He's a principal investigator in more than 30 global clinical trials. And he's a recipient of Sanofi Lectureship Award at Epicon in 2016. He was invited as guest faculty at various national as well as international conferences. He has many publications.
Keep the introduction part, Dr. Badlan.
Okay. So he's the first diabetes. Okay, sorry. Then we have third speaker, Dr. Uddha Jadhav from Mumbai. He's a consultant in cardiology as MGM New Bombay Hospital, and he's a professor and faculty, Maharashtra University of Health Services. He's actually involved in research, and he was awarded many. He was given many awards and award sessions at American College of Chest Physicians, International Critical Care Congress, CSI, API, Hypertension Society of India, and Indian College of Cardiology in last 5 years. So this is the introduction for all the three speakers. And now I invite the first speaker, Dr. Soumitra Ray, to speak on dapagliflozin in the patients of heart failure.
Thank you, the whole team, Cardiocon, the respected chairpersons, Dr. Sharma. Would you allow me to share my screen, please? Please allow me to share my screen.
Yes, you can share your screen.
Just give me a minute to share my screen. I think you can't see the full picture now. Are you seeing the full screen? Not yet. Just give me one more bow. No, are you seeing the full screen?
No.
No. Okay. Just a minute. Can you see the full screen now?
No. You put it on slideshow, sir.
Okay. Just a sec. Now you will see. Now you can see the full screen, now. Just tell me whether you see the full screen.
Okay, done. Yeah.
Yeah, done. Yeah. Okay. Thank you, Dr. Sharma, for starting the day with the lovely doctors talking about yoga and diet. I was almost going to decide to start yoga and dieting from tomorrow, but I resisted at the last minute. So today's talk is that dapagliflozin is the preferred choice of SGLT2 in this person. Look at this person. A 95 kg Indian male on optimal cardiac medicine, has diabetes with A1C 8.2, BMI 34.5. Remember, ejection fraction 40%. Remember, history of CABG 2 years back, please remember. Now, dapagliflozin is the preferred SGLT2, and why not? The choice is actually clear if you do not want to break the law. And Dr. Sharma is a very law-abiding person. He already put empagliflozin in the red corner. He put remogliflozin in the yellow corner and gave me with dapagliflozin to go ahead with the green-blue corner. So the choice was made not by me, but by Dr. Sharma. Thank you, Dr. Sharma. But there is a myth that in presence of ASCVD, empagliflozin gives a MACE benefit, which does not give what the dapagliflozin in DECLARE does not give. But you see, EMPA-REG had all 100% ASCVD patient, and DECLARE TIMI had only 40% ASCVD patient. And if you see dapagliflozin, as far as the ASCVD group of those 40% is concerned, you have got a clear benefit in cardiovascular death and heart failure hospitalization with 17%, and the confidence interval does not exceed 1. So if it is ASCVD, dapagliflozin as good as empagliflozin. And that is shown by here also. If there is MI within 2 years, beyond 2 years, you get even MACE benefit, not only the death benefit and hospitalization for heart failure benefit. And if you see the meta-analysis of EMPA, CANA, and DAPA, you will see that ASCVD, everybody is a meta-analysis showing good result. But for multiple risk factor, it is not showing good result. Meta-analysis is important because my subsequent speakers will show meta-analysis. If you believe their meta-analysis, you have to believe my meta-analysis as well. So all three SGLT2 have shown benefit that are limited to ASCVD patient. MACE benefit, remember. So there is a myth that presence of ASCVD, EMPA gives MACE benefit. It is not. It depends on the molecule. It does not depend on the molecule. It depends on the patient profile. If it is ASCVD, everybody gets benefit. If it is any patient, you will get heart failure benefit. But heart failure cannot be judged from those two trials because only 10 to 15% of those patients were heart failure. So we have to fall back on DAPA heart failure and emperor-reduced trial for our patient. And DAPA heart failure showed clearly an astronomical p-value for benefit for dapagliflozin for the cumulative benefit of heart failure and cardiovascular death. And the individual component, if you see, they have got ischemic cardiomyopathy more than 50%, even with DAPA. So DAPA is not an ischemic, that is a totally wrong idea. Even in DAPA heart failure, more than 50% people had ischemic cardiomyopathy. And what did DAPA show? There's a significant benefit in heart failure hospitalization, and there is a significant benefit in cardiovascular death. But the EMPA showed there's a significant benefit in heart failure hospitalization, but no benefit in cardiovascular death in emperor reduced. So EMPA couldn't reduce risk of cardiovascular death. And all-cause mortality is also very important, isn't it? And DAPA showed a 17% reduction of all-cause mortality. P-value is 0.02, which is significant. And emperor showed only 8% benefit of all-cause mortality, which is not at all any different from the placebo. And DAPA also showed the composite ventricular arrhythmia and sudden cardiac death reduction by a p-value of 0.03, which is again significant. Does EMPA has any data on reduction of composite ventricular arrhythmia, resuscitated cardiac arrest or sudden death? Not yet published. If it is not yet published, I can't talk about it. So DAPA and EMPA in these two trials, cardiovascular death, only DAPA. All-cause death, only DAPA. And even onset of new diabetes in pre-diabetic people, only DAPA. EMPA fails miserably in preventing diabetes as well. Now I talk to my patient over here. Now you see, dapagliflozin shows the benefit from BMI 15 to BMI 50. There is uniform benefit. But you see here, very interesting. EMPA has got no benefit when your BMI is more than 30. Emperor reduced, go back and see the trial. If the BMI is more than 30, emperor has got no benefit to this patient. And what is the BMI of my patient? 34.5. So emperor has got nothing to do in this patient. Now, ejection fraction from 10 to 40%, dapagliflozin shows benefit in death, in all-cause death, in heart failure hospitalization, uniform benefit. Here you see the emperor reduced. If ejection is above 30%, absolutely no difference with placebo. It's on the neutral line. And what is the ejection of my patient? 40%. So no question of giving empagliflozin in a fat person of ejection fraction 40%. What is the positioning of DAPA in recent guidelines? In 2020, only 2 years ago, Heart Failure Association of ESC said by naming it that dapagliflozin should be given in HFrEF. What is the Canadian said? That recommended SGLT2 inhibitor such as dapagliflozin, which is a representative molecule with and without concomitant diabetes. But also Dr. Sharma kept remogliflozin. Why? No reason, except personal obligation. To write for me, if the company people say, sir, please write 1 or 2 prescription, I might oblige them. I should not. But no presentable data whatsoever. Of course, price matters. Of course, price matters. I know that. Empagliflozin made in Germany, 15,000 per year. Remogliflozin made in India, 8,000 rupees per year. Dapagliflozin, if it is made in Sweden or UK, 16,000. If you search in certain apps, you will get it an 8,000 home delivery. But dapagliflozin in India, 5,000. Remogliflozin in India, 8,000. Dapagliflozin made in India, 5,000. Of course, I am concerned about price. That's what I will give dapagliflozin. So if my patient is rich, I'll give Forxiga over Jardiance. If my patient is poor, I'll give a DAPA India rather than a Remo India. So for this patient, DAPA scores over other SGLT2 because it is the only molecule which causes reduction of cardiovascular death and all-cause mortality. It is the only molecule which is applicable for BMI above 30. It is the only molecule which is applicable above ejection fraction 30. It is the only molecule which prevents ventricular arrhythmia and sudden cardiac death. And it is the only molecule which is best affordable of all the SGLT2 available wherever it is made in the world in India. So for this case, Dr. Kamal Sharma told that for empagliflozin, do not proceed, a red light. For remogliflozin, you think twice. And for dapagliflozin, just go ahead. Just write the prescription. Thank you, Dr. Sharma, for this favor toward me and all other here for being law-abiding citizens. I stop over here. Thank you.
Thank you, Dr. Soumitra Rai. Now we will go to Dr. Sanjeev Pathak.
Yes, good morning, and thank you, Dr. Kamal Sharma, Dr. Jayesh Trivedi, Dr. Badlani. May I be invisible?
Yes.
Yes, sir.
Is it in the full screen mode now?
Yeah. Continue.
Okay. So thank you very much, all the delegates and all the faculty members who have joined. And thank you, Dr. Soumitra Ray. I know you are a very learned cardiologist, but the patient who has come to you, he has not just come to you for heart failure management. He has come to you for overall management. And that is why the patient, after going to Dr. Soumitra Ray, has now come to me because he received dapagliflozin and could not get the control. Why so? I'll explain you in next few slides. First, let me clarify that this is not about the red signal or green signal. This is about the boxing bouts where red is put in the favorite position, whereas blue and green probably are the fighters, but most probably the favorite is red. So here, the favorite one is empagliflozin, and obviously I'll vote for empagliflozin, not in this particular case, but for any diabetic patient who is having history of cardiovascular disease. No need to remember that with heart failure, give dapagliflozin, without heart failure, this, kidney failure, this. You just need to remember one gliflozin, that is empagliflozin. Why so? I'll explain in next 8 to 10 minutes. Well, our patient, 34.5 BMI, A1C is 8.1 controlled, CABG before 2 years, LV ejection fraction 40, which may be 45 with the other cardiologists. Dr. Soumitra Ray knows this very well. Presently is on the guideline-directed medical therapy, which obviously includes metformin, and he now needs, according to any guidelines, an SGLT2 inhibitor. Which SGLT2? It has to be empagliflozin. What are the aims of management for our patient? First and foremost is the glycemic control, not just heart failure. You need to prevent the microvascular, macrovascular, all the complications. Second is weight loss, prevent the cardiovascular event, prevent heart failure hospitalization, and obviously reduce mortality. Let us look at the glycemic control. And then there are meta-analyses which have been published even in 2019, has shown that compared to dapagliflozin, which is in the dotted graph, EMPA gives better HbA1c reduction, better fasting control, better weight reduction, and better systolic blood pressure reduction. And this is meta-analysis of 7 studies from Asia. Regarding the cardiovascular events, we very well know the EMPA-REG outcome, that a robust 32% reduction in the all-cause death with empagliflozin when used in type 2 diabetic patients with cardiovascular disease. And this patient, the patient which Dr. Kamal has referred us, is having cardiovascular disease. He has already undergone a bypass surgery. So you can expect 32% cardiovascular as well as the all-cause death reduction. And this reduction is across the categories of the CV death, whether the patient had fatal MI, fatal stroke, heart failure related death, sudden death, whatever it is. And this is again, regardless of the various types of CAD. In this particular patient, we have 2 things. One is patient is prior CABG, significant reduction. Patient also has heart failure, again, very significant reduction. Again, this is regardless of the CVD manifestation, whether the patient is having PAD, stroke, prior heart failure, prior atrial fibrillation, whatever it is, patient will benefit. You need not remember whether the patient is having ejection fraction 40 or 42, whether the patient is having bypass surgery or not. You give empagliflozin and it is one-time solution for everything. Look at the cardiovascular outcomes. Everything is in green. This green signal is important, not that one. EMPA-REG, 3-point MACE, CV death, heart failure, everything is significantly reduced. Unfortunately, declared TIMI showed only heart failure reduction. So it is a heart failure drug, not a diabetes drug for that matter, I can say. Asian patients, our patient is Asian, and obviously you can see significant benefit in Asian patients in the empagliflozin, whether it is 10 milligram or 25 milligram. And based upon this, we know that empagliflozin became first and the only OAD approved for reduction of cardiovascular death in patients with type 2 diabetes with established cardiovascular disease. This is what our patient is having. And this is not just based on one study, that is EMPA-REG. Apart from EMPA-REG, the meta-analysis of 7 phase 3 studies, not including EMPA-REG, has also shown significant benefits in 4-point MACE, 3-point MACE, cardiovascular death, and heart failure hospitalization. Let us look into heart failure now. EMPEROR reduced 25% relative risk reduction, 30% in the dapagliflozin. In one of the studies, Dr. Soumitra mentioned that DAPA had 17% reduction, where EMPA had 38% cardiovascular death reduction in type 2 diabetic patients. Here, the difference is only 5%. But if you look at the absolute risk, there is not much of a difference. Again, the adjudicated total hospitalization for heart failure, first and recurrent, 30% risk reduction with empagliflozin. Both the populations were different. Ideally, we should not compare these 2 trials, but for the sake of comparison, the overall baseline risk was much higher in the EMPEROR reduced compared to the DAPA-HF. Moreover, in the EMPEROR reduced, the patients were either on ICDUs or CRTUs or ARNI. That means they were receiving the guideline-based therapy, and on top of that, empagliflozin could achieve an additional benefit, which was not the case in the DAPA-HF trial. So regardless of heart failure is there or not, diabetes is there or not, empagliflozin in diabetic patients has definitely given much better results compared to dapagliflozin. And that is true not only with reduced ejection fraction, but also with preserved ejection fraction. more than 40. This patient is having ejection fraction of 40. With some other investigator or cardiologist, it's maybe 45 also. We know it is a subjective thing. Across the category, empagliflozin has shown benefit. We very well know, I'm not going to details of that, whether it is CV death, hospitalization, whether LV ejection fraction is 41 to 49, whether it is 50 or more, or whether it is less than 40, EMPA will give you benefit. And this study again, this meta-analysis again shows, even if it is below 25 or 25 to 35, or even more than 65, EMPA is going to give you cardiovascular benefit, not just the heart failure benefit. Moreover, patients who had higher background risk and those who were treated with the ARNI-like therapy or CRT or the devices, still empagliflozin could give benefit. The meta-analysis published in the Lancet 2020 also mentioned that both the trials show significant benefits, and these benefits are almost similar. There's hardly anything compared between these two. If you look at the kidney composite outcome, both emperor reduced and emperor preserved showed better kidney composite outcomes compared to the DEPA-HF or declared TB, meaning thereby that not only heart failure, but also in the kidney-related endpoints, empagliflozin scores over dapagliflozin. So it confers significant and meaningful CV benefits in patients across the CV risk continuum. If you look at the patients with low risk, medium CVD risk, phase 3 meta-analysis, significant benefits with EMPA. EMPA-REG outcome in diabetic with established cardiovascular disease, benefit. Again, patients with prior CABG, benefit, which is the case in this patient. With preserved ejection fraction, benefit as per the emperor preserved. With reduced ejection fraction, benefit as per the emperor reduced. What are the other benefits that are unique to empagliflozin? Maybe there with other gliflozins, but not well documented. One is the blood pressure reduction, whether it is nighttime BP, daytime BP, 24-hour BP. The SACRA study showed that empagliflozin reduced the systolic blood pressure by 6 to 10 millimeter of mercury. How about obstructive sleep apnea, which this patient is very likely to have? Very, very significant reduction by empagliflozin in the risk of OSA, 52%. And we know very recently one of our famous Bollywood personality died due to obstructive sleep apnea. Hepatic fat content, both Indian studies as well as the Western studies have shown that empagliflozin reduces the liver steatosis and fibrosis. Well, this may be there with Remo and DEPA, but not so well documented as compared to empagliflozin. So let us compare finally with DEPA and Remo. I could not find any comparative study. So the 3-point MACE, CV death, all-cause death, everything very, very favorably affected by empagliflozin. With dapagliflozin, none of these factors have been affected in diabetic population. And that is why it is the only SGLT2 inhibitor officially recommended to reduce the risk of death in diabetic people. I'm not talking about heart failure also, I'm talking about diabetic as a whole. So I have 3 medicines, all 3 drugs will reduce your blood sugar. But let me ask my patient, one drug will save your life, and that is empagliflozin. Whether you are having heart failure or not, whether you are having heart failure with mildly reduced, or preserved ejection fraction, this drug is likely to save your life. Well, talking about the cost, we Indians are always innovative. We doctors are no exception. We can cut down the cost by making the empagliflozin half. So by spending 10 rupees extra, if you are going to save the life, I think that's worth doing it. And we have data with both 10 and 25 milligram of empagliflozin that they are equally effective, not only in reducing the HbA1c, but also in the cardiovascular outcome, whether it is EMPA-REG, EMPRISE, or Emperor preserved trials. Finally, glycemic control, you can say EMPA is slightly better. Remo, we do not have any comparative data. Whatever data is there with dapagliflozin is compared. Weight loss, almost equal. CV events, overall, empagliflozin has more benefits compared to DEPA. Remo, people will ask, what's that? What is CV events? Reducing mortality, Remo, there is no data. Empagliflozin, there is stronger data. Heart failure, slightly better data with dapagliflozin, but EMPA has data even in the preserved ejection fraction. Sleep apnea, much better data with empagliflozin, no data with the other drugs. Liver fat, better data with empagliflozin. Half dose of EMPA is effective. SGLT2 receptor affinity, much more, and that is probably the reason why empagliflozin scores over the other drugs. Kidney
Give it
injury,
up 30
risk
seconds.
is minimal. Bladder cancer, no debate, no risk. DEPA was initially not approved for this reason. Amputation, probably we have no data with rather. There is a typo error here. It should be not Cana, remogliflozin in the last box. So EMPA is a clear winner, not only for heart failure, but for cardiovascular events, for the renal events, for weight reduction, for sleep apnea, for liver fat, everything. So I would rest my case here with empagliflozin being the best drug amongst the SGLT2 inhibitors. Thank you very much. Thank you for your very kind.
Superb, Panak.
Now, Dr. Uday Jadhav.
Thank you very much for allowing me this opportunity, respected chairpersons, Dr. Kamal Sharma, and the entire team from Cardiocon. So let me share the slides and make it quick. I promise you I'll save your time. So first thing first, am I well heard before I go ahead? And is the screen visible?
Yeah, yes, you are audible.
Very nice. So the last slide that Dr. Sanjeev Phatak showed, you saw remogliflozin in that marathon trying to climb up to the other molecules. And therefore, I rightly put this, that this is an uphill climb. So I was surprised that I was given this heading that it is the most studied molecule in the heart failure. It cannot be anywhere near the real truth. It is the least studied molecule in heart failure. I go by the science. I do not try and protect what I want to say always, but still I'll put in few very important thoughts. So let's talk of remogliflozin. And so what is the premise on which I would base this 7-8 minutes presentation? One is that it is a class effect of SGLT2 inhibitors. It is just that in the hierarchy and the historical trials as they come through, each molecule proves its worth. So if EMPA worked in is that it is a class effect and it's just the hierarchy or the historical evolution of molecules in SGLT2 inhibitors that decides how things work, but they all work. It's a class effect. I think this debate is reasonably useless for EMPA and DEPA. Both work very well. And for that matter, all SGLT2 inhibitors are going to work very well. The question is, Remo being the least studied, does it stand the merit of evidence as on today's date? Look at an analogy of calcium channel blockers, right? Amongst the CCBs, it's only amlodipine, which is the gold standard and has been thoroughly studied. Not a single one of the others, Silni, Azalni, Benodipine, not a single one of them has a CV outcome study or even a reasonably good outcome study. And yet, both medical professional doctors and their families have been on CCBs. And that's on for the last 10 years. What makes that happen? Because there will not be a clinical trial that will evolve with any other CCBs. And therefore, it will be impossible to tell you whether cilnidipine will change the CV outcomes. But don't you prescribe it to the patients? Don't you take it yourself or in the family, right? The same would work with most of the SGLT2 inhibitors. So that's my first pretext. Second, and I'll show you why SGLT1 inhibition is an important concept. And third, whatever evolutionary data has come up over the next last 2-3 months. So here is a comparison between Remo and dapagliflozin. That was the initial launch study of 10 milligrams of dapagliflozin. And what did it tell us? Very quickly, it showed us that at 6 months, the HbA1c lowering, the fasting lowering, and the postprandial lowering was non-inferior. You may call it little superior if you want, but certainly non-inferior, even if the p-values are taken in consideration. So the clinical development, which started in 2019 and 20 by Glenmark, who brought it in India, continued. And the real world assessment came from 4 clinical studies. They involved more than 11,000 patients. That was the INSPIRE data. The INSPIRE, after the head-to-head study between DAPA, was a real world experience trying to show what happens in real world in 11,000 patients. And the HbA1c reduction was lesser, 0.95, as compared to the baseline. Fasting sugar went down by 42, and the postprandial sugar also went down significantly. Body weight down by 2.6 kgs, BMI by 1 kg per square. It's absolutely comparable. All these 5 parameters are absolutely comparable with EMPA, DAPA, any of the SGLT2 inhibitors. The systolic and diastolic blood pressure of 3.3 and 2.3. Very comparative. It's very interesting to see that even in the real world data exceeding 10,000 patients, there wasn't really any difference. GU infections were 12.5, and I, for one, am a proponent saying that let's not rub that under the blanket. The clinical trials, even with EMPA, DAPA, tell you it's 0.3 to 3. Well, that's not true. Believe me, in clinical practice, you will see 10 to 12%. It cannot be lesser. Whatever be the severity. Lab parameters, the uric acid and the USCR, 2 things that influence cardiovascular effects, morbidity, mortality, and heart failure got improved. So here is the comparative data from INSPIRE, and it tells you it's absolutely similar. Whenever you compare EMPA, DAPA, CANA, it's absolutely similar. And my second pretext. This is a SGLT1 inhibitor. Mind you, the SGLT2 inhibition with EMPA is way high, right? If I correctly remember, the T2T1 affinity for the receptor and the inhibition is 3,500-fold and is the gold standard. With our remogliflozin, it's 365 T2T1 inhibition, so more T1 inhibition. I'll show you the data with SGLT1 inhibition, primarily with sotagliflozin, which has a 20-fold affinity. So a very strong inhibition of SGLT1 inhibitor, right? Is this important? Of course. Unlike SGLT2, SGLT1 has an expression in the cardiomyocyte sarcolemma and the capillaries. This has been proved in human autopsy rats, in murine animal models, and this entire expression on the cardiomyocytes is glucose metabolism dependent in the heart with SGLT1. In end stage of cardiomyopathy in type 2 diabetes, SGLT1 expression is the most comparative to SGLT2 expression. So what am I saying? SGLT1 expression and its inhibition certainly, potentially, theoretically has to make a difference to the human heart. But is that only theory? No. Look at the Soloist WHF data. Primarily, strongly SGLT1 inhibitor, Deepak Bhatt's presentation, where he tried to look at all stages, preclinical, clinical, and the detectable cardiac involvement. That's where you can place Remo exactly like SOTA. It's used for WHF, for hospital discharge, and after 3 days, right? Look at the difference it has made. The difference is so huge at 28 days. The hospitalizations at 28 days and was significant at 0.035 since randomization. These are the events of urgent HFE visit. Here is the data. Let me tell you one very important thing. Now we are talking about EMPA in HFpEF as a prospective trial, but it was not EMPA. The whole story started with LVEF less than 50 and more than 50. Look at the effect of SOTA, a SGLT1 inhibition in SOS and HFpEF. It's even more robust than HFrEF. Unlike all the other molecules, mind you, even with EMPA data, the lower the EF, the better you get for heart failure. Here is a molecule where even when the EF is not as low, more than 50, EMPA at 55, 60 is just about neutral. At more than 50, SGLT1 inhibitor is very, very strong. So I think that's important. Makes a difference in all parameters before and after. That's the LVEF data. Keep that in mind with SGLT2 inhibition. Here is the pool data of 11,000 patients. Deaths, heart failure hospital, urgent HF, CV deaths, everything gets better. Everything gets better. And this is my last slide, but a very important slide. This slide must be preserved because it's DAPA, Emperor, and SGLT1 and 2 inhibition by soloist WHF. Look at the third one, that small little dot. It scores better than everything, the one above. Even if you don't want to separate the beef from the shaft, still it tells you SGLT2 inhibition and SGLT1 inhibition on top of that will make a difference. So REMO is not the most studied, ladies and gentlemen. It has a potential. If you study it, it will be like any other CCB in the SGLT2 class. It will prove its worth. The molecule has a place, sure and certain. Now, whether prospective trials are going to come off, I do not believe. There is the Revolution studies that are coming up with the originators in India, and there are a few others in heart failure segments, in diabetic segments, in NASH, but leave that aside. If you are waiting for an international study to come through, no, it's a Japanese molecule. It won't come. Will it come with sotagliflozin? You bet. It's already proved its worth beyond everything else. Thank you very much for the patient hearing. I may have to move on to another meeting for ICCON, so please spare me in case I have to go in between. Thank you very much.
Kamal, unmute. Kamal, unmute.
So I think one thing which comes clearly from the discussion. I am audible?
Yes, continue, Dhiren.
Yeah. So mortality benefit versus morbidity benefit with SGLT2 inhibitors. So suppose we are keeping mortality benefit only in our mind, then of course, as per the all presentation of the science, I think EMPA will come first, then DAPA, and with REMO there are no other data available to show the mortality benefits. But morbidity benefits, I think all the three have are doing equal good. So what is your comment, dear speakers and the other panelists also?
May I have a quick say? I'm Dr. Soumitra.
Yeah.
As it is said very nicely by Dr. Phatak and Dr. Jadhav as well, I see more patients of heart failure every day, proved heart failure. And I see ischemic cardiomyopathy and non-ischemic cardiomyopathy, both, you see. So if you see, the case was not very completely shown. We need to know the bypass occurred more than 2 years ago. How is the patient from ischemic standpoint? If he's taking, say, sublingual nitrate every day, if he's having a dynamic ECG changes, if he's getting admitted for ischemia and getting treated, then of course ASCVD is the primary disease here, and perhaps by evidence, empagliflozin is the first choice. But if the heart failure predominates and it's a burnt out ASCVD, then if they coexist, heart failure determines the future, not the ASCVD. The patient dies of heart failure and consequences, not a failure of graft. 2 years graft, in a good surgeon, this graft will last for 20 years without any problem. But heart failure, we need medical management. And for HFrEF, the dapagliflozin has got, if you see these two last, not EMPA-REG or not declared TIMI, those are not heart failure trials at all. Only 10% heart failure patient. Whereas in these heart failure trials, 50% had ischemic cardiomyopathy. So they are more representative of my patient. And here dapagliflozin has got a very clear age. But having said so, 40% ejection does not mean anything. We do not know whether the patient is symptomatic or not. And it is not a diagnosis of HFrEF. HFrEF diagnosis means symptom plus minus sign plus an ejection fraction below 40%. So just an ejection 40%, I cannot say even this patient has got heart failure. But if it is a patient is in heart failure, DEPA, if he has got ongoing ischemia, EMPA, if it is an ischemic cardiomyopathy, maybe either, but DEPA, remogliflozin is definitely has got future. Only thing is that it is twice daily dosing. And that sharply reduces compliance. That sharply reduces compliance for any medicine. That's my take.
One thing.
Hello.
So that is why if you give empagliflozin, you are never going to be wrong. Dr. Kamal intentionally did not give the full information. I think so. Regardless of
the incomplete information is
regardless
always
of
to
the
trigger
BMI.
a debate. You're right. So
Yes.
I kept.
So regardless of that,
so
if you give empagliflozin, you will never be wrong. 2%, 5% here or there. You
then
will
we'll
never
not
be
have
wrong.
debate, Sanjeev bhai. Then only you will be speaking. No. I was to mention. So I think the whole idea was to promote SGLT2 in heart failure. We need to have, irrespective of ischemic, non-ischemic, diastolic, systolic, SGLT2 inhibitor has to be there. I think evidences are emerging, as Dr. Uday Jadhav mentioned, for remogliflozin in Revolution study. I think that would be the largest SGLT2 data from India when it gets through. The class effect is for heart failure is very well known. We have studied that in even the ertugliflozin, which had similar trial design like EMPA, but failed in the trial. But still, heart failure was reduced. It did not reduce the MACE rate, mortality rates, but it did reduce heart failure rates. So heart failure hospitalization is a class effect. Mortality may not be, depending on how sick patients, what is the inclusion, what is the exclusion criteria that we get. So I think everybody should get SGLT2. I don't think there is any doubt about it. What to choose again?
On top of the MRA beta blocker.
Absolutely, absolutely, absolutely. So chairpersons, if you can, chairpersons, if you can have, we can have your viewpoints on this, and then we can conclude the session.
Kamal, we have to clear the confusion among the physicians.
Absolutely. So chairperson,
now the first is suppose patient,
Pavan Roy or Dr. Nilesh Purushottam.
Yeah.
More comments?
Yeah, I'm very happy to hear. Thank you, Dr. Kamal sir. I think everything is well discussed, and point is, as you said, heart failure in heart failure management and in secondary prevention of atherosclerosis, ASCVD, this molecule should be there in the prescription in all patients with and without diabetes, especially in heart failure without diabetes, and if patient has a diabetes with atherosclerosis. Among the choices, that positive points and negative points of all molecules that we have already discussed, and it is almost similar like what statin we have to use, either atorvastatin or rosuvastatin, something like that. So according to me, it is a class effect, and Remo is an Indian brand, but that evidences are emerging. So till the evidence, we can use any of that, either DAPA or EMPA, as we discussed. Thank you very much.
Hi, good afternoon, sir. I am Dr. Pavan Roy. Thank you, Kamal sir, for inviting me for this conference. Actually, any patient who admitted this heart failure, starting the SGLT2 inhibitors from the first day, I've seen some patients going into lactic acidosis or inherent UTI, which may not be detected if we don't do urine RM. So in such patients, there may be worsening of UTI or even dehydration if the patient has already been ongoing on Lasix or direct infusion. So I have a doubt that whether we should start SGLT2 inhibitors a few days after the acute LVEF episode recovers, or we can start on admission only.
So most of the times, I think we end up doing this is that we make the dose of diuretics half when we add an SGLT2 in such scenario where the patient is already stable on
it.
And I think the whole idea what Dr. Dhiren Bhai was asking was that heart failure means an SGLT2, of course. You have very strong evidences for established ASCVD because of the trial design rather than the effect per se. But then I strongly still believe that the SGLT2 upon SGLT1 ratio is also an important determinant how significantly a molecule may or may not have impact on CV outcomes. But again, it's a subject of speculation rather than evidences. We believe because it works more so for EMPA in the EMPA-REG outcome, rather than DAPA-HF, which trial design was different. But I think DAPA people learned it by default in the trial design, and that's how in Emperor Preserved, you could not achieve mortality reduction, but you could do that in DAPA-HF, which they learned from the failure that they had in mortality. Declared to me, they could not achieve a mortality difference. So when you choose patient subgroups which are sicker, you probably end up finding more evidence-based reductions. And that's why it's more important that when we interpret a trial, we also look at their inclusion-exclusion criteria rather just interpret their results per se. So I think in patients with established ASCVD, as of now, with sick LV, with IHD, EMPA probably holds an edge. DAPA also has evidence for it. Non-ischemic, as Dr. Soumitra Ray mentioned, denying these patients gliflozin, either of the two, you still have evidence for if you're believing in class for remogliflozin. That's my take. Open to any of the speakers or chairpersons to have any additional comments on that, and then we can end the session.
Can I make a comment? Can I make a comment here?
Sure.
Actually, he was telling about UTI. See, it has been seen that UTI is not a big problem with SGLT2 inhibitors. It's only genital mycotic infections which can happen rather than UTI or even pyelonephritis or cystitis. So it's not UTI. It's only genital mycotic infections which can have problems rather than. That's what is my comment. That's all.
Yes, fully agree with you, Dr. Raghu.
Absolutely. I think, may I make that comment? That just to be sure, we talk about mycotic infections. The very little, let's not call them even UTI, but in certain circumstances, let's say catheterized patients, for those who are undergoing urological surgery, one of the experiences, they do get symptoms of urethritis. So I would be probably a little careful in the Euro setting, of starting a SGLT2 inhibitor immediately. I would let this procedure settle down. Cystoscopies, digestantings, patients who have hospital-acquired UTIs, nothing to do with SGLT2 inhibitors. These are the patients where you don't want a little more trouble. So they do create a little urethritis. But besides that, you're absolutely right. It's not UTI. We don't use that term. It's simply mycotic. Well corrected. Yes, it's all mycotic.
So I think we have made it. It's a long time.
Everything is clear now. Yeah.
I have one question, please.
Yes, sir.
This is going to be the last question, please.
Okay, yeah. Can we start SGLT2 inhibitor in patient with asymptomatic bacteriuria detected first time and patient with heart failure?
Yeah.
Asymptomatic bacteriuria, when you get
you can.
60% in
you can start. If the patient doesn't have any fever, I think you can definitely start. Yeah.
I think we have discussed this in one of the forums where Dr. Sanjeev Phatak was also there. A good strategy in such cases is if the more amount sugar is thrown when your glucose is more uncontrolled. Once you attain good glycemic control and add an SGLT2, the amount of glycosuria may be lesser and hence likelihood of UTI would be lesser, whatever is infection you're saying. So if a patient's sugar is 400 and you're giving an SGLT2, you're likely to have more glycosuria because the renal thresholds are at 70. And hence these are more glycosuric and hence probably more UTI. So if you're controlling diabetes well with your diabetologist and adding an SGLT2, then the glucosuria is lesser, but the heart failure benefits still exist, as we know from DAPA-HF, where even in non-diabetics it works. So if you're so much worried, ask your diabetologist to, add an insulin, think of SU, whatever other things that you can do and are safer in heart failure. And on top of that, then you come in maybe in a day or two with an SGLT2, probably you will not end up. But again, this is anecdotal thing and just a physiological extension or argument, otherwise not paper and data. But of course, if the incidence of UTIs in DAPA-HF was 2%, much lesser as compared to the other trials. That is because if you're non-diabetic, you don't get UTI. That's the evidence for it.
Thank you. Thank you, sir.